Good afternoon. We are going to start this session. We are going to talk about point-of-care ultrasound in perioperative care. My name is Vincent Chen from University of Toronto. I'm going to partner with Dr. James Donato from Harvard Medical School. I will cover the non-cardiac and lung ultrasound applications, and James is going to talk about cardiac and lung. This is my email address. We may not have time to answer a lot of your questions, but please email to me later on. So these are my disclosures, but it shouldn't affect my presentations at all. So lately we talk a lot about point-of-care ultrasound. Many editorials. This one appeared in Anesthesiology last year, talk about teaching whole body point-of-care ultrasound, advancing the skills of tomorrow's anesthesiologists. I think it's a new frontier for us. It's very exciting. And this hopefully will replace the stethoscope that we hang around our neck. Also importantly, the technology has advanced significantly. Not only that, it is laptop sized. Now there are many, not many, but several pocket-sized ultrasound machines available. So it's smaller and smaller technologies that are getting better and better. So what can we image? I think for point-of-care ultrasound in this editorial in anesthesiology is talk about eye, airway, lung, cardiac, and abdomen. I think it's very comprehensive examination, but the most important thing we want to emphasize is the focused ultrasound examination. And we follow the I-AIM framework. I stands for indication, A stands for acquisition, I stands for interpretation, and finally M stands for medical decision. So we're not suggesting that everyone should buy an ultrasound machine and start scanning the patient and just fishing around and look for something. I think it's an extension of physical examination. We should first of all have a history physical, have a differential diagnosis, and use the ultrasound or focus examination to help us to tell what the diagnosis is. Acquisition, obviously hands-on experience. That's why there are many workshops help us to acquire images. And if we don't have a good image, if we don't have an optimal image, it will be very difficult to interpret. So optimal imaging is very important so that we can look at anatomy, the physiology, and also recognize artifacts and pitfalls that may lead us to a wrong impression. And finally, decision-making. We have to accept that what we capture with ultrasound can help us with the diagnosis. It may not help our diagnosis, but also we have to acknowledge that we are not sure, and we just have to accept it and ask for proper evaluation by other specialties. I think what is important to me is we are now switching the focus of ultrasound. We have been historically using it for regional anesthesia, pain, and vascular access. They are all ultrasound-guided interventions, helping us to put the needle more accurately in the right place. The focus, I believe, is now more a diagnosis. And diagnostic purpose, we are using the airway to look at airway, breathing, circulation, and the abdomen. And more importantly, we don't have it yet. For critical care physicians, they have ultrasound curriculum. I think it's important for us, particularly for the non-cardiac anesthesiologists, we should develop ultrasound curriculum for focused ultrasound examination. I hope this will come soon. So first, I'm going to talk about some of the lessons we've learned from gastric ultrasound. Why do we worry? Obviously, some patients are high risk. It's obvious. These patients may have a high risk of full stomach, had a risk of pulmonary aspiration, and we obviously worry about solid. It's high risk, a large amount of fluid, low pH. And without seeing what's inside the stomach, all we can go by is guidelines, right? There's so many guidelines out there. How long do you have to fast before you come to the operating room? So that's why we started to ask ourselves, can we use ultrasound to look at the stomach? And when we first did this study in volunteers, we looked at the fundus, the body, and the antrum of the stomach, and we find that the antrum is most consistent. The body can be horizontal, can be vertical, and it's difficult to define what is normal size, and the fundus oftentimes has air, so we're not able to see it. So when we do the imaging, we use a curve probe. It's a low-frequency probe. We're doing a sagittal scan. We either scan the patient supine or in the right lateral decubitus, because when the patient is in this right lateral decubitus position, this content of the stomach is going to gravitate towards the antrum. The internal landmarks, ultrasound landmarks, are very easy. Look for the liver. Look for the back, the spine. On top of the spine is either the aorta or the IVC slightly more to the right. And then underneath, inferior to the liver, you will see the antrum, and behind it is the pancreas. So these are all the landmarks you need to know in order to find the stomach. When you look for the wall of the stomach using a linear probe, you can see 5 layers of the stomach. And the ones that we pay attention to are the muscularis propria and muscularis mucosa. These are the 2 layers that are very dark. So hypoechoic, it gives the stomach a ring shape. So this is what you see for the longitudinal sagittal scan. The liver is here, the abdomen curve probe, a little bit of abdominal muscle here. You see as the subject swallow, you can see something swelling here. You kind of appreciate the dark ring around. So this is what you see. Someone is drinking. It's very easy to see that. So recognize when the stomach is empty. Again, a very dark hypoechoic boundary here, the wall of the stomach, and the mucosa of the stomach is collapsed, and this is what you see there. When the stomach is filled with clear fluid, fluid is very dark, hypoechoic. This is outlining the stomach very well. When you have something thick, fluid, or solid, this is what you see, a very homogeneous white inside. When you have solid mixed with some air is even more hyperechoic, and that's what you see, the speckle of air inside. And this is what happens when someone has just eaten. When you eat, you swallow a lot of air, and this is the interface of air, and underneath air, you cannot see what's inside the stomach. But it's important to look at the surface of this air interface. That is already the size of the stomach. So this is already big. So we call it the frosted glass appearance. So you have to wait. You have to turn the patient on the right lateral decubitus position when you have that situation. Wait about 5-10 minutes or even longer. Get the air to flow up, and then you may be able to see what's inside. So it takes a little time to do that. So then next thing is you want to look at this cross-sectional area. The ultrasound machine has the ability, you can trace it. You can now look at it, and it gives you a cross-sectional area. And once you determine the cross-sectional area, you can go to this reference. It's for adult. This is particularly for fluid work. The formula is for fluid, right lateral decubitus. And it's important also to notice that when you have a cross-sectional area determined, you also have to look at the age, because for a younger individual, for that cross-sectional area, the total volume is bigger than someone who is older. So this is the age-dependent factor. Alternatively, you can look at it qualitatively. This should be qualitatively. When it's grade 0 is when the patient is supine or lateral, you cannot see the stomach. So you know there's nothing in there. Grade 1 is when you have the patient supine, you don't see anything. Right lateral decubitus, you begin to see the stomach distended. And grade 2 are the patients that we really worry about when you see the stomach distended, both supine and right lateral decubitus. So how does it guide our clinical practice? If we can really see solid in the stomach, we consider high risk. We delay surgery. If we see fluid, it depends on how much. If it's less than 1.5, it's low risk. Even someone who's fasted will have about 100 mils in the stomach. That's normal. Grade 2 is greater than 1.5 mils per kilo. That's what we consider high risk. And you can treat the patient. You can give maybe some Maxtran, and then you can do repeated bedside examination, non-invasive. So that is very good. In the case that you cannot see the stomach, you are not sure, then you just follow the guidelines. So that's all I'm going to say about the stomach. It's very practical. We have used this now in our daily practice. Airway ultrasound is slightly different. I consider airway ultrasound is still in the experimental phase. There are certain clear indications, but other indications we are still looking and find out what ultrasound can really help you. There are a number of references now. We did one in 2010, and Dr. Christensen from Denmark, he has done a lot of work in there, in this area. So you can use either a linear probe or a curved probe. Obviously, a curved probe will allow you to see more, the wider field of view, see deeper. But most of the airway structures are superficial, so you can use the linear probe to do that. So either transverse or sagittal. So what do we see? You can see the hyoid bone very easily. You can divide into what you can see above the hyoid bone or below the hyoid bone. This is the hyoid bone. So above the hyoid bone, you can see the base of the tongue that you don't usually see by inspection. You can see the soft palate. And this whole area is air, so you would not be able to see the posterior pharyngeal wall because of air unless someone has kept fluid in their mouth, that you can do that. And then below the hyoid bone, through this window, you can have a glimpse of part of the epiglottis. Over the thyroid cartilage, if it's not ossified, you can see the vocal cord. And underneath the thyroid cartilage, you can see the cricothyroid membrane, the cricoid cartilage, and the rings of the trachea. So the one thing that I think will be very helpful to us as anesthesiologists is where to find the cricothyroid membrane. In case you cannot intubate, cannot ventilate, you may want to mark it before you put the patient to sleep. So this is the thyroid cartilage. The cricoid cartilage is very obvious, it's very dark, it's superficial, and it is hypoechoic. So the line above it, it forms an air mucosal interface. It's a very bright line. This is the cricoid thyroid membrane. So you can use a paper clip and mark it, and then you can just leave a mark there. The best way I find to find it is do a sagittal scan from the trachea and go up, because when you do that, you can see the cartilaginous ring of the trachea, the air mucosal interface, air artifact inside. The first big hypoechoic structure here is very superficial, is the cricoid cartilage, and then slide the probe further up, you will see the cricoid thyroid membrane. So there are a number of studies. Emergency physicians have done a few for cadavers. I think the one that is most important for us is in someone maybe have a thick neck with poorly defined neck anatomy, maybe have radiation and so forth. You don't know where to find. You cannot feel the cricoid cartilage. This is where you can use it for. Through the thyroid cartilage, you can see the vocal cord. When you phonate, you can see the movement of the false cord. So how does it help you? Some people will look at the vocal cord movement after thyroid surgery using Doppler. If you see this, you know this side is moving, that side on the right side is not moving. Some people also look at it to predict post-extubation stridor. In addition to leak tests, they are going to look at the vocal cord. I don't have any experience with this. This appears in the critical care literature. When it's a normal situation, when the tube is there, when the balloon cuff is inflated, you look at this window, this air column. When the cuff is deflated, you see that this column, the width is wider. So this is normal. That means there is a good leak. But in the case of vocal cord edema, they find that before the deflation and after deflation, there is no change. So this is one indication of vocal cord edema. Another study, they look at how much the difference is normal. They find that it's about 1.6 millimeter. So this is normal when you see that it's widened. So I hope that more studies will be done in the future to validate this. Other things is when you have subglottic stenosis, or in children, instead of using a formula, you can also use ultrasound to look at the diameter of the cricoid cartilage. and then you can measure it transversely. You can see this U-shaped structure. You can now go across, and you can have an estimate of the diameter. So it's well correlated with MRI imaging. What about endotracheal tube placement? You think, why bother? If you can see the tube going through the vocal cord, obviously it's there. But there are situations that you will not, because sometimes it's difficult intubation, you're outside the OR, you don't have CO2 tracing, and the patient may be a cardiac arrest situation or cardiac arrest with low pulmonary flow, you cannot detect CO2, or you may be in a helicopter, you cannot hear with auscultation. So these are the times, this is a time I think you would want ultrasound to help you, because you will be able to see the tube in the esophagus if it's in the wrong place. So the esophagus is actually very easy to see, particularly on the left side. You can see the trachea here, the transverse process of the vertebral body, and then you see the esophagus on each side. You can ask the patients to swallow, and you can see it. If it is now the tube is there, not only you see the trachea, but now the tube is there. The image is kind of small. It's hard to see, but this is a tube with a ring around it. You know that the tube is in the esophagus. So recently this article appeared. I learned something from this article. When you have the tube inside, blow up the balloon with air. And when you blow up, see how the trachea distends. This is how they test. When you scan from the thyroid cartilage all the way down to the suprasternal notch, look for the dilatation. Then you know before you ventilate, you already can confirm the endotracheal tube is in the right place. Some other people will look at it with ventilation, obviously look at the lung sliding, and then some people also look at the one lung ventilation using MO. Again, look at the movement of the lung as one way in addition to auscultation. So those are the things that we can do for lung ultrasound. I hope that there will be more applications. The next thing is the diaphragm. We started to look at diaphragm because when we do blocks, after interscaling block, patient complain of shortness of breath or supraclavicular block. Is it a pneumothorax or is it paralyzed diaphragm? Again, use a curved probe. On the right side is very easy, a mid-clavicular line. The liver is your friend. You can go through it very easily. The left side is more difficult because the spleen is small. So this is the right side. You see the liver, the kidney, the spleen is smaller. The diaphragm is very clearly a bright line. And when they ask the patient, again, a qualitative assessment, take a deep breath in. You see the diaphragm comes down on both sides. You can also use the MO. You can detect the amplitude, how much excursion the diaphragm has, and do it before and after. Ask the subject to sniff. You will see these peaks. Again, you have an idea of the amplitude. So this is after interscaling block in the patient. You still qualitatively, before, afterwards is flat. It's not moving anymore. So you know the diaphragm is flat, and most of patients don't have any problem. They are asymptomatic. This is before the MO. You can see a big peak. Afterwards is nothing, so you know that. Finally, I'm not an expert in the optic nerve sheath diameter, but this is, again, things that I believe we can do to help us to assess intracranial pressure at the bedside, particularly when the patient doesn't have an ICP monitor. You may want to do it serially and see what our anesthetic practice would affect the ICP. I think this is one thing we can do. Use a high-frequency probe, go through the two chambers of the eye through the lens, and this is the optic nerve. The optic nerve is part of the CNS system, and the optic nerve is surrounded by CSF and is in communication with the subarachnoid space. So any time when there's a raised ICP, when there is no obstruction to the CSF flow, you will see a distension of the optic nerve sheath. And you see a series of pictures here showing how you do it. In fact, when you actually do it, this is the wrong thing to do. First, I think instead of putting the gel right on top of the eye, many people will put a tegaderm, a transparent dressing to protect the eye, then put the gel over it. The next thing is really stabilize the hand because you don't want to be moving around. And in fact, you don't need to have the probe right on top of the eyelid. Lay a thick layer of gel, and you can just gently put the probe on the gel, and you will be able to image it very nicely. And finally, when you scan, use an ocular protocol. You want to make sure that you don't heat up the chamber, and also make sure that you have a nice axis and not an off-axis view. So where do you look? You look at the optic disc and 3 millimeter deep to it and go across perpendicular, and this is where you measure and do a few readings, both transverse and sagittal, and compare the two sides. Hopefully one side you can use it as a reference, as a baseline. So there are pitfalls, and make sure that the two sides are perpendicular, parallel and not widened, because there are artifacts that may make you think that the optic nerve sheath diameter is larger. So you can see that there's a whole, it's not a straight line, there's a range of optic nerve sheath diameter. In this study, they find that from when the ICP is less than 20, it's about 0.4. When it's greater than 20, is 0.53. Another study, when they look at the MRI imaging, again, they use the cutoff point of 0.58. So it depends on what the cutoff point is. If the higher the cutoff point, obviously, it will be very specific, but it will be less sensitive. If you drop the cutoff diameter to lower, then it's more sensitive, but less specific. So I'm going to end here. I'm going to ask James to talk to you about lung and also cardiac imaging. Thank you.
So hopefully at the end of this, I'm going to convince you that, that both cardiac and lung ultrasound are actually pretty simple. They're not as complicated as people would lead you to believe. So let's get right into this. Once we get rid of the Hilton stuff, right? Okay, so I'm going to be talking about both cardiac and lung ultrasound. I've got nothing to disclose. We're going to talk, at the risk of insulting people's intelligence a little bit, we're going to talk a little bit about transducers and what different kinds of transducers you use and why you use them and what they mean. We're going to talk a little bit about 2D and M mode. We need to know about M mode because it comes up repeatedly in lung ultrasound. We're not going to spend a lot of time on color flow Doppler, pulse wave Doppler, and continuous wave Doppler because we're not going to have time for that today. But if you're interested, we can talk a little bit more about it. So when we're talking about transthoracic echo, basically, if we're doing a focused exam, this is what we're looking for. We're looking for qualitative assessment of LV and RV function. We're looking for some assessment of volume status, and we're trying to rule out catastrophes like pericardial tamponade. That's when you do a focused transthoracic exam, that's what you're looking for. When we do lung ultrasound, basically we're looking for pneumothorax. We're attempting to rule out pneumothorax. We're looking for effusions. And we're also attempting to make some determination of whether the patient has a lot of lung water or pulmonary edema, which quite honestly you can do pretty easily with lung ultrasound. And the other is it becomes helpful in recognizing atelectasis. For instance, when you have a right mainstem bronchus intubation, we use it all the time. The fellow puts an endotracheal tube in, you slap the ultrasound on the patient's chest, and you can tell in 2 seconds whether the lung is moving or not without spending time to auscultate. All right, so let's talk about transducers. So basically, the thing to remember about transducers is the higher the frequency, the prettier the picture, but the less depth of penetration you're going to get. So if I'm doing a transthoracic exam on a newborn baby, I can use a 12 megahertz transducer and get beautiful pictures. If I put a 12 megahertz transducer on my chest, I'd be lucky if I could see below my ribs, because I'll get great resolution but terrible depth of penetration. So the trade-off when we do this is we want to use transducers that have a compromise between penetration and resolution. And so we're generally talking about transducers that have between 8 and 4 megahertz as their frequency. If we use something like this that goes to 13 to 6 megahertz, we could get very high resolution at 13, for instance, if you're doing nerve blocks, but you're not going to get very much depth. All of the transducers now, the Sonosite machines and all of those machines, have what's known as frequency agility, meaning that as you go deeper, the frequency of the transducer goes down in an effort to let you see further in, but you lose resolution. Okay. The other thing is we're going to talk about, there's a little notch on the side of the transducer. At the risk of insulting people's intelligence, we need to remember what that's about. Okay, so if the little notch, think about the notch side being the green side of an apex and the other side being a red side. And you've all noticed this annoying little dot that shows up on all the echo pictures, and you wonder what the heck that is. And sometimes it's at the bottom of the screen, and sometimes it's at the other side of the screen. One of the sources of confusion is different specialists put the dot in different places. So the ED guys, when they do transthoracic and lung ultrasound, they have the dot in a different place than cardiologists do, which may be different than what anesthesiologists do. The only thing to remember is where the dot is the side that corresponds to the green side of the apex. And by convention, you make it so that stuff on the left side of the patient's body is on the right side of the screen. That's all you have to know. So you find the notch, you point it towards something, you know that that's the green side. So here we're doing this apical view. The green side is over here. We're looking at the apex of the heart. The marker's over here, so that green side of this apex is going to be on the right side of the screen. That's all you have to know. And when you see people flip the images around and upside down and backwards, all you need to remember is the dot is always going to be on the side that has the notch of the transducer on it. Okay. So the other thing we need to know about is M mode. So when you use ultrasound, you're getting about 30 frames a second of resolution, which is pretty reasonable, but it's not great. M mode is a single line. It's just a single line that cuts through the screen at 1,000 frames a second. So it has incredibly high resolution, but it only takes that picture through that one line. And so if I take this short axis view of the ventricle and I put an M mode probe through it, all I'm going to see, this is time, over and over and over again, is that same spot going again across the screen. So what it does, it allows me to see a single spot over and over again at very high resolution. That's all you need to know about M mode. Okay, so that's your 2D picture. That's your M mode picture. We're not going to talk a lot about color because we don't have time today, but the thing you need to know about color is just remember the word BART, blue away, red towards. And when you use color, the top, you can always tell where the towards the transducer is because it's the apex of the triangle. And any color that is blue is going to be away from the transducer, blue away. So there's severe tricuspid regurgitation. The color's going away. It's going from the RV into the RA. And anything that comes towards the transducer is going to be red. You just remember BART. We don't do a lot of color when we do fast ultrasound exams, but as you get more into this, you may want to start doing that. Okay. And here you can see just another example of that same thing. All right. The only other thing you need to know is what coronary arteries supply what part of the ventricle. Because if you're looking at an adult and you're worried about coronary ischemia, you want to know what distribution of coronary artery the badness is. Well, I'm here to tell you the secret to that is we're going to look at short axis views. You can spend hours trying to memorize these different views and what coronaries are seen. You don't need to do that. All you need to find is a short axis view of the ventricle. And in the short axis view of the ventricle, here's one at the base, here's one at the mid-level, at the papillary muscle level, here's at the apex. What do you see about this? every coronary artery shows up for the party. So you can assess the flow in every coronary artery by looking at a short axis view. And if you're looking for wall motion abnormalities in regard to coronary ischemia, this is where the money is without having to memorize all this advanced stuff. Okay, so let's talk about the views. We're going to talk about basically 4 views. We're going to talk about parasternal long, parasternal short, apical, and subxiphoid. Okay, so, and this comes from the PIE website, P-I-E, which comes out of Toronto. It's a beautiful website. It's free. It's got interactive videos. It's a fantastic website if you want to do self-learning for echo. All right, so we want to get a parasternal long axis view. What are we going to do? We're going to put the transducer in the 3rd or 4th intercostal space. We're going to take the little marker, see it up there, and we're going to point it towards the patient's right shoulder. And then we're going to look at this picture. And you can see, right, there's pointed towards the right shoulder. There's the green side. There's the marker. We're going to picture that looks like this. And what's it really going to look like? It's going to look like this. We're going to see the aortic valve here, the mitral valve here, the left atrium here, a little bit of the RV there, and all of LV here. So what we can look at the aortic valve, the mitral valve, and we can get a pretty decent assessment of LV and RV function off this view. Pretty simple view. Standard parasternal long axis view. You can see up here, right, we've got our orientation again. Okay. The beauty of that is that once you get that view, once you're in that 4th intercostal space pointed towards the right shoulder, you can either tilt the probe up or tilt it down, right? You're not moving, you're just staying in the same place and tilting the probe. And if you tilt anterior, you're going to see more of pulmonary artery, right? Here's where we started. Now we're going to see pulmonary artery. And if we tilt down, we're going to see more of the body of the RV right here, which allows us another view to assess RV function. So if we have a patient that we think has a pulmonary embolus, or we're worried about RV function, and we get a parasternal long axis view, we can tilt the probe a little bit posterior and get a nice view of the RV. And what would that look like? That would look like this, where we have RA, tricuspid valve, and RV, and we can get a pretty nice assessment, qualitative assessment of RV function there. Okay. All right, so now we're going to move from there to the parasternal short axis view. So what do? We have the probe pointed towards the patient's right shoulder in the 3rd or 4th intercostal space. We basically just rotate it 90 degrees and aim it now, right, towards the patient's left shoulder. And we're going to get this parasternal short axis view, and I'll show you some pictures of that in a minute, that's going to show us this. There's the aortic valve in the middle. That's the RV. RV outflow tract, tricuspid valve in the left atrium. So here, we can tell a little bit about the aortic valve. We can tell a lot about the tricuspid valve. We don't know much about the LA except it's posterior here. But this is the view, if you're really interested in looking at the aortic valve and the RV outflow tract, this is the view that you would want to get. All right. And, of course, and in the stylized view, it's going to look like this, right? Aortic valve in the middle, RA, tricuspid valve, RV outflow tract. All right. And then the beauty of that view is once we get that view, by tilting down towards the patient's feet, right, taking the scan's like this, and tilting towards the patient's feet, we can start getting into the money views where we now start getting RV and LV short axis views, which we're going to use, is going to be our primary way of determining function. It's going to be used for volume assessment. It's also going to be used for wall motion abnormality. So we start here, we get this nice picture, and then we sweep down. And what's that going to look like? So now, from that same view, I've swept down just a little bit, and I'm going to get the LV here. What's this thing? That's the mitral valve. Looks like a fish mouth. And I've got RV here. So I can, if I've got a wall motion abnormality here, if there's one area in this donut that isn't moving well, right, I know which coronary it is. If it's out here, it's the circumflex. If it's out here, it's the LAD. And if it's back here, it's the right coronary. That's all you got to know. And then the RV, obviously, is going to be a little bit of circumflex and a lot of right coronary. And we can get a very good assessment here of function. And we can also start to get assessment of volume status. And what are we looking for when we look in volume status? We're looking in diastole, right? We're looking for when the donut is the biggest. to get a sense of how full the ventricle is. The thing to keep in mind is that if the ventricle completely collapses down on itself, that doesn't really tell us that much about volume, because having low afterload, being very, very vasodilated, will do that as well, right? The ventricle completely empties out. So we're more interested in what it looks like when we're full in diastole. And you can see here now what we've done is we've swept down a little further. We're at the mitral valve and we sweep down a little further. And now we're looking at a short axis view of the LV. And we've got some RV here as well. All right. And then you can see here is a difference, right? This is the whole sweep. So there I am. We're going to start at the top here. There's the aortic short axis view, and now you sweep down. You can see the mitral valve, and then we're back up, sweeping up towards the aortic valve in one big sweep. All right. The next view we're going to talk about is the apical four-chamber view. This is another view. And so you say, well, why do you need all these views? Well, you don't really, but you can't always get great views in every location in the same patient, so you need to be a little bit flexible. And one of the things we're going to talk about, right, none of the views I've shown you so far are worth a damn if you're doing CPR on somebody, right, because their hands are in the way. When we talk about the subcostal views, that becomes much more valuable, because I can get subcostal views on someone I'm giving chest compressions to. All right, so we're talking about the apical four-chamber view. We're here now, we've slid over, right? We're in the fourth or fifth intercostal space, so we've slid down a little, and we're sliding out laterally towards the patient's nipple. We've got the marker aimed towards their right shoulder, right, our little triangle there, apex of the triangle, and we're going to get a four-chamber view. And what are we going to see there? We're going to see, there's the dot. That means the stuff on the left side of the patient's body is over here, LV, RV, tricuspid valve, mitral valve, LA, RA. And you can see, again, this is a pretty good way to assess function and volume status, because we get a good view of both ventricles and both valves. And when we start getting more sophisticated, if we wanted to do Doppler, Doppler interrogation of one of these valves, we could do that because we're going to be parallel to it. The Doppler probe is going to come from here, and we're parallel to it, which is the mainstay of doing Doppler interrogation. All right. And then it's the same thing from the apical four-chamber view. By sweeping, we can look at other structures. So if I sweep anteriorly from the apex, I'm going to be able to see the aortic valve. I'm going to get this five-chamber view. From here, I sweep up, and from here, I sweep down. I'm going to be more posterior. I could actually even start to see the coronary sinus there. Okay. And there's an example of us sweeping up. Now I can see the aortic valve, which would allow me to Doppler that valve because I'm parallel to it here. Okay. All right. And then as an example, now what we're going to do is we're going to talk about the subcostal four-chamber view. So this is the view, right? I said you're doing CPR on a patient and you want to know what their function looks like. I'm going to take the probe and I'm going to put it right under their xiphoid process, push down on their stomach, have my marker pointing to their right shoulder, and I'm going to get this thing that looks very much like that apical four-chamber view we had, except now I'm using the liver as my site to allow sound to come in. And the liver obviously is great because it's a solid structure, so I get really pretty pictures through there. And I can get exactly the same view, or a very similar view to what I got with the apical four-chamber view. You can see here, there's my tricuspid valve, my RV, my LV, and my LA there. Same little markers there. Okay. All right. Now, the other thing you'll hear people talk about is using the subxiphoid view to assess volume by looking at the IVC and respiratory variation in the IVC. So what I'm going to do here, I'm going to be in the exact same place, except I'm going to point the marker, my marker up, straight up, and I'm going to take this picture where I have RA here, right, RA on the green side, and the IVC on the red side. And what I'm going to do is I'm going to assess volume status by looking at respiratory variation and the caliber of the IVC. And it's really simple, right? It's just this Starling resistor. If my pleural pressure is greater than my mean circulatory pressure, which is greater than my CVP, my IVC is going to be collapsed. If I'm in this middle condition where, depending on whether I'm taking a breath or not, my pleural pressure is greater than my mean circulatory pressure, I'm going to see respiratory variation of my IVC. And if I have catastrophically high systemic venous pressure, say from RV failure or volume overload, there's going to be no respiratory variation whatsoever in my IVC, and I'm going to show you that. So we're going to get a couple of different pictures here. So you can see the three examples. Here I have collapse throughout inspiration and expiration. This is the RA, this is the IVC. So you could look at that and say this is a patient who's hypovolemic. If I look here, you can see I get respiratory variation in the caliber of the IVC, which would lead me to believe that they're probably euvolemic, or at least close to being euvolemic. And this would be the kind of person here where their CVP and their mean systemic venous pressure is so high that you would expect that they had severe RV dysfunction. You can also see that little stuff in there that it looks like contrast, spontaneous contrast. That's indicative of a low flow state when you see spontaneous contrast like that. The next thing that happens when you see that is thrombus. All right, so let's just quickly look at a couple of these. I'm looking at, this is my short axis view again. Remember, this is a parasternal short axis view. I've got normal function and then moderately depressed function. You can see it's all qualitative. I mean, there's nothing magic about it. You're making an assessment. And you can see here that I have the ventricular walls are kissing in systole, right? The thing you have to be careful about that is that could be consistent with hypovolemia, but it could also be consistent with intense vasodilatation, that the ventricle completely empties when it ejects because the SVR is so low. Okay, and then if I look at this one, it's clear here that this ventricular function is severely depressed, and you can also see there's badness going on in this wall motion, right? This thing isn't moving at all. It's just rocking. So there's something going on in the LAD there. Whereas here, over towards the septum, it looks a little better. Okay. And again, same sort of thing, using my parasternal long axis view and parasternal short axis view to assess RV function. Here you can see the RV here looks depressed. The LV looks great, but the RV is dilated and not contracting very well. And if I do the same thing here in my apical view, I see the same thing, right? The RV is dilated compared to the LV, and it's not contracting very well. Same here. All right. Let's talk about lung ultrasound. So lung ultrasound, a lot of mystery about lung ultrasound. It's really easy. A couple of very simple concepts to get in mind. You'd be able to do this the minute you go home and try it on a patient. All right. So basically, you're going to use the same sort of transducer we talked about, and you're going to orient it. If the ribs are here and here, I'm going to orient the transducer up and down, right, with the green, the marker up, so the green side's up, the red side's down, and I'm going to pick spots. I'm going to pick between the second and third intercostal space, just next to the sternal border. If I want to get fancy, I can move down laterally, and if I'm looking specifically for pleural effusions, I can move down posteriorly. But if you're looking just for atelectasis or a pneumothorax, basically you just need to be able to look in these two places on the right and the left. Okay. And what are they going to look like? So let's talk about normal stuff, okay? So this is our friend Narcissus, or a cardiac surgeon, depending on how you think about that. And basically what you're doing with lung ultrasound, the pleural line, okay, the pleura, the parietal pleura and the visceral pleura acts like a mirror. So above this is just soft tissue. It's fat and muscle and stuff like that. And then below this is just a reflection of that. So this is the patient's soft tissue, and this is a reflection of the patient's soft tissue underneath there. When there's no air in there, right? When there's air in the lung, all you're going to get is this reflection. And this pleural line, what's going to happen, you can see there's a reduplication of it right here, we're going to talk about this a little more in a minute, is called the A line. And what happens is ultrasound comes down here, it bounces off this, it goes back to the transducer, comes down, bounces off, bounces off. Well, ultrasound interprets time as distance. So if I send an ultrasound wave here and show this, and it bounces back here and comes down again, what's it going to do? It's going to look exactly twice as far, and then 3 times as far, and 4 times as far, and I'm going to see A lines. And what I'm seeing here when a patient's breathing is I'm going to see this thing called lung sliding, where you can see the lung sliding back and forth. That's what it looks like when a lung is being ventilated. Unfortunately, it doesn't always look that nice. And that's where M mode comes in, because when you put M mode across this, what you get is this thing called the seashore sign, where this is the ocean, and this is the nice sandy beach where you got your toes. So if you can't see lung sliding, and trust me, all the pictures always show it as something you always see. You don't. You put M mode on it and you look for this. And if you see the seashore sign, then you know that that lung is ventilated, and you know there's not a pneumothorax. Because if you have a pneumothorax and there's air in here, we don't get this reflection anymore. All right, so let's talk about one more thing. When you have to use your imagination a little bit, but remember, we have the ultrasound probe between these 2 ribs, and people have said that that looks like a bat. So they'll call that the bat sign between the 2 ribs. When you hear that, the veterinarians call it the gator sign, but it's the same. It looks like a gator with its eyes coming out of the water, just sticking out of the water. Okay, so here you can see that we have something going on here, something that looks like movement, but we don't have that lung sliding anymore. So then the question is, what is that? Well, when we put M mode across that, we get this. It's not the pretty seashore sign anymore, right? What does that look like? It looks like a barcode. That's the barcode sign. And the barcode sign means that the lung isn't moving. So it's atelectatic. So this would be what you would get like if you had a main stem bronchus intubation. There's no lung sliding, and I'm getting this barcode sign. This thing, this bouncing, is what's called lung pulse, which is, and you've all seen this when you on an end tidal monitor, right? When you're not ventilating a patient and their end tidal does the cardiac oscillations, same thing. What you're seeing here is lung bouncing up and down, non-aerated lung bouncing up and down from cardiac pulsations. All right. So you can see there, what we're doing now is when you're looking for a pneumothorax, what you're looking for is what's called the lung point. So watch this picture. I'm going to start here. You're going to see lung sliding. See it? You had lung sliding there. And now I'm scanning and I don't have lung sliding and I've got all this other stuff. That's known as the lung point. And the lung point is basically 100% diagnostic for a pneumothorax, meaning I scan in one place, I see lung sliding. I scan in another place and I don't see lung sliding. The only thing that does that is a pneumothorax, as opposed to atelectasis, where I would see the barcode sign everywhere, right? Here, I switch from the seashore sign to the barcode sign, and here in the same picture, I get them both. So that's a pneumothorax. All right. And then this one's easy. What's this? This is just a bunch of fluid, right? This lung is floating around in a bunch of fluid here. That's called the quad sign, where I have my lung here, which is collapsed, right, and is pulled away from the chest wall, and it looks like there's fluid there. It looks like a quadrangle. So you can see there's kind of stuff floating around in there. See it? That's a big pleural effusion. All right. And then here, we've got a little bit more of the same. It's not the greatest picture in the world, but you can see that I've got a gigantic pleural effusion here because I've got collapsed lung down there, right, that almost looks like tissue. So a very big pleural effusion there. All right. So let's talk a little bit about A lines and B lines, because B lines are what we use when we're looking for pulmonary edema. So Here's the structure of your lung. When you get pulmonary edema, you get fluid in these intralobar septi. That's where pulmonary edema fluid accumulates. And remember, we said A lines were this reverberation off the pleural line back and forth, where I get these evenly spaced lines. B lines are ultrasound beams bouncing back and forth in these intralobar septa because they're full with fluid, and I get a pattern that looks like this. It looks like a comet tail. So if we go back to our friend Narcissus here, if this is normal, I'm looking at a normal ultrasound and I see my reflection above and below. When I have B lines, it's like putting a ripple in the water. I can't see my reflection anymore above and below, but I see these little ripples in the line. And all these little ripples are called B lines. When you have B lines, they completely erase the A lines. I can't see any A lines in here. And that's lung water. That's pulmonary edema when you see that. You would be, in the world I work in and all the little kids we have that are coming for, AV canal repairs or an ASD repair, they may have a chest x-ray that actually doesn't look that bad. They all have big-time B lines. And it turns out B lines by ultrasound are actually more sensitive than picking up subtle degrees of pulmonary edema than chest x-ray. All right, so here's an example of some B lines. See if I can. There you go. And this would be an example of bad B lines. They're very close together and they're everywhere, and they're erasing all the A lines that I would see there. So here's your B lines. This is another example of pretty bad B lines. You can see there's the pleural line. I don't see the reflection of the A line going down. And then just as an example, I've got two other versions of B lines, one that's not so bad and one that's quite bad, as a way of grading pulmonary edema. So this is the way that a lot of ICU people now and a lot of medicine people in particular are taking this up as a way of workups for hypoxia to rule out pulmonary edema, or what would be called by a radiologist as alveolar syndrome. Okay. Oop. The Wi-Fi keeps wanting to come up. So I want to show you one last thing. Remember I said the lung pulse. So this is, over here is an example of a lung that there's no lung sliding, right? You don't see it sliding back and forth. So this would be the example of a main stem intubation or a completely collapsed lung. It's not a pneumothorax, right? Because we can see some a few B lines and stuff going through there. But the difference is looks like a lung pulse, but it's not. This is somebody being transcutaneously paced. And what you can see here is the tissue, their soft tissue's moving. It's not their lung that's moving. It's just interesting. I don't know how helpful this is, but it just shows you the difference between a lung pulse and actually soft tissue moving. You might see this, the only reason I mention it is you might see this in someone who's in extremis, right? Who's really dyspneic and using a lot of accessory muscles. They might have chest wall movement that's pretty dramatic, which is in fact not a lung pulse. All right, so let's just summarize. This is the current consensus guidelines on looking for a pneumothorax. Because one of the things people with lung ultrasound, what it really started with was looking for ruling out pneumothorax. So let's just go through this. Okay, so I want to rule out a pneumothorax. The surgeon just put a subclavian line in. I'm worried. I think the kid or the adult might have a pneumothorax. I put ultrasound on and I look, and do I see lung sliding? Well, if I see lung sliding, there ain't no way there's a pneumothorax there. If I look around some more and find a place where there isn't lung sliding, and now I'm looking for the lung point, then maybe we have a pneumothorax. But if I put it in a particular place anteriorly on the side where they just stuck the line, and I see lung sliding, there is not a pneumothorax there. Okay, if I don't see lung sliding, then I got to ask myself, do I see B lines? And if I see B lines, I can't have a pneumothorax, because remember, in order for there to be B lines, ultrasound has to go into the lung and hit fluid and bounce back and forth. If there's an air space under the pleural space, I'm not going to see B lines, because I'm never going to be able to see the ultrasound bouncing back and forth in the fluid. So if I don't see B lines, I have to be suspicious that I have, if I see B lines, then I can say I don't have a pneumothorax. If I don't have B lines, then I need to go on the hunt for a lung point, right? Remember I showed you the lung point. And if I see the lung point, then I know I've got a pneumothorax. If I don't see the lung point here, right? So no lung point, then I can move down to lung pulse. And if I see a lung pulse, I can't have a pneumothorax either, because I'm not going to see the lung pulse if there's air between the pleural space and the lung. I'm only going to see a lung pulse if the lung isn't moving but not collapsed. So when you see a lung pulse, you want to think main stem intubation or not ventilating one lung. And then obviously over here, if I see the lung point, I definitely have a pneumothorax. All right, thank you.